Welcome to the March edition of IIDR Rounds. I'm Lori Burrows. I'm the Associate Director of the IIDR. I'm really excited for today's topic, which is the future of antimicrobials for gram negatives. This is a topic that's on the top of a lot of people's minds. So our speakers today are Dr. Brody Duncan, who is a medical microbiologist, infectious disease physician, and assistant professor in the Department of Pathology Molecular Medicine. He's the program director for the Medical Microbiology Residency Program and lead for pediatric medical microbiology. He's also doing his master's part-time in Andrew MacArthur's lab, learning how to use bioinformatics tools to predict antimicrobial resistance. So today he's going to be discussing epidemiology and management of multi-drug resistant Enterobacteriales. Our second speaker today is Dr. John Stokes, who is an assistant professor in biochemistry and biomedical sciences and a member of the IIDR. His lab develops and applies AI models for drug discovery tasks with a strong focus on new antibiotic discovery for drug-resistant pathogens. And today he'll be discussing generative AI for new antibiotic design against gram-negative bacteria. So I'm really looking forward to your talks. If people have questions, please put them in the Q&A and we'll answer them at the end of the talks. And I will now turn it over to Brody.
So yes, hello everybody. My name is Brody Duncan. Today, to get right into it, I'll be talking about some updates on carbapenemase producing Enterobacteriales, or CPE, subtitled "The Antibiotic Arms Race Continues." I think sometimes in medicine we use like war metaphors a little bit too frequently and inappropriately, but I think for this topic, I hope that I'll share that this is definitely very active ongoing battles on a global scale. So in terms of the schedule of what we're talking about today, I'm going to very briefly just remind ourselves what are CPE, because I think most of us are familiar with this topic. Talk somewhat about the epidemiology in Canada. I'll very briefly go over treatment. I'm not going to spend a long time on that because you can see at the bottom there's been a lot of recent IIDR talks by some of my colleagues talking about some of the more specifics of treatments for different organisms. And then I'll move into talking about variants for some of our more common carbapenemase enzymes. I'll also say I'm just a medical microbiologist. I'm not a biochemist. This is not like my hyper-focused area of research. So if anyone has any interesting tidbits of research to share at the end, I'm more than happy to hear it, because this is just like a broad overview of some of these topics. So first, a reminder, what is a carbapenemase? So a carbapenemase is a beta-lactamase that uses carbapenems as substrate. So I think all of us know that if we have our enzyme and then we bring it with the carbapenem, some biochemistry magic happens, which obviously is not actually magic. There's a lot of intense biochemistry that happens. And at the end of it, we have a hydrolyzed carbapenem, which is no longer active. And then that allows the bacteria to survive and continue to cause infection. The issue and the scary thing is that most carbapenemases give resistance to all classes of beta-lactam, not just carbapenems. So you can see on the right here that if we're doing disdiffusion for, I think this is an NDM-producing enzyme, it's penicillins, cephalosporins, combination beta-lactamase inhibitors like piptazo, and carbapenems that are all resistant. There are some novel agents being invented that kind of try to get around this, which I'll talk about later, but these are very scary enzymes, very clinically relevant, very epidemiologically relevant. A quick reminder of the Ambler classification. You could spend like a whole day just talking about this slide, but I'm going to spend 1 minute on it. So reminder that for carbapenemases especially, we're really focusing on the Ambler class because that does have clinical and laboratory relevance. Ambler classification is based off of the molecular mechanism and structure and relatedness. So if we look at Ambler group A, these are our most common serine beta-lactamases, and KPC would be like the prototypical carbapenemase that falls in that class. Class B are our metallo-beta-lactamases, like IMP, VIM, and NDM. These are very different than our serine beta-lactamases because they have a metallic enzyme, usually a zinc, at the active site. So they've got a very different mechanism, even if the resistance phenotype is very similar. AMP-C is the most common Ambler class C beta-lactamase, and luckily, so far, there are no carbapenemases of clinical relevance in class C. And then D is our OXA group. This is a very broad and diverse group where you can have super narrow beta-lactamases, super broad carbapenemases, and OXA48 is, again, like the most common OXA that we would be worried about for carbapenemases. So moving into the epidemiology of CPE in Canada. CPEs probably first appeared in Canada around 2007, 2008. This is a paper from a Toronto group describing just in Toronto, like you can see that for those first couple of years, we would get like the occasional CPE, which at that time was always just KPC, and they were always imported from somewhere else, right? Like we did not have any CPE in Canada. And then at a certain point, a few of them started appearing, usually from travel and patients hospitalized in places where they were more common. However, you can see that over the following years, there was an exponential increase in the number of CPEs being found in Toronto, and there was also a diversification of the enzymes. So you can see that even by 2015, it was a pretty good mix of NDMs, KPCs, OXA48s, some VIMs, which is another metallobalactamase, which is not as common these days. But this is a very scary trend that has definitely continued to this day. You can see in this paper, which is more recent data from 2019 to 2020, that on a national level in Canada, KPCs, NDMs, and OXA48s remain our top threats, with KPC being about 42%, NDM being about 32%, OXA is about 18%. But you can see there's also a number of these other like very random and uncommon enzymes like GES and IMP and again VIM, which are much less common but do occur, right? And if you are a patient with that, it's important for us to be able to detect this. And I think that this national data anecdotally matches what we're seeing in Hamilton in the past year or two quite accurately. The thing that's really scary is that CPE is becoming endemic in Canada. So in this paper, when they look at the source of acquisition, you can see that about 20% of these isolates were still healthcare associated outside of Canada, but 72% were healthcare associated inside of Canada. So in the past couple of years, now we have patients that have these extremely resistant, difficult to treat superbugs, where their only risk factor is that they were hospitalized in a hospital in Canada, which again is a very scary thing thinking about the future. So I really want to emphasize that this data is showing that we are living through a period of immense change. Like the way that we think about and look for and treat CPEs is very different 10 years ago than it is today. And you always have to be careful when you're looking at the literature that, again, even just being a couple of years out of date could mean that the situation is massively changed. Looking at some local Hamilton data, so I gave a topic rounds right before the pandemic on CPE back in 2020. And when I looked at the previous year, I had found 7 clinical isolates for the entire year that were CPE expressing. And it was mostly KPCs with a few NDMs. So again, 7 for the entire year. And then earlier this week, I went into my electronic medical record and we had been isolating in our laboratory 20 to 50 isolates a month. So this is not, perfectly statistically valid data because the denominators are not the same between all of these groups. But again, I think that in my anecdotal experience, this really matches up that CPEs are becoming more common. They are becoming more diverse. And we are really putting a lot of effort into finding them and treating for them, even compared to just a year or two ago, right? So who knows where we'll be a year or two from now. Emphasizing again, we are living through a period of immense change. The way that we are treating and detecting these things 10 years ago is not the way it is today and not the way it's going to be 10 or 20 years from now. And that's just from an epidemiology level. A piece of good news is that CPE have not yet had a major impact on a population level in Canada. So if we look at 2009 national data for E. coli, you can see that 100% of isolates were meropenem susceptible. Contrast this with 2021 national data for E. coli, 99.8% were meropenem susceptible. So even though we're seeing a lot more CPEs compared to the baseline CPE rate on a population level, these are still just a tiny drop in the bucket. CPEs are not affecting our empiric treatment of gram-negative infections or other community-acquired infections in Canada at this point. However, it's not always going to be that way. If we look across the Atlantic, this is a screenshot from a European paper that came out last year based on 2021 data, where you can see that the countries that are in dark blue, which is mainly Western and Northern Europe, if we look at their Klebsiella pneumoniae, less than 1% are resistant to carbapenem. So these are very similar to our rates here in Canada. If we look at our dark brown countries, they have more than 50% resistance to carbapenems among their Klebsiella pneumoniae. So if you live in Greece or Ukraine or Russia and you have a Klebsiella pneumoniae infection, it is more likely than not that it is going to be one of these carbapenemase resistant organisms, which are often CPEs. So again, this is a very scary thing. I think that we can be grateful that at least for now, national borders seem to be somewhat effective at slowing things down. but it's kind of like the ghost of Christmas future, where it's like, if we don't change our ways, this is how we could end up. And this would be a terrifying thing. Although maybe even if we change our ways, this will happen. These things are a bit unpredictable. So that's what I wanted to say about epidemiology. Moving into the treatment of CPE, I'm going to, again, try to be brief because there's been lots of other topics that talk about this. Novel beta-lactam agents are very exciting in a positive way. So ceftazidime avibactam is probably the most top of mind agent here, where ceftazidime is a broad cephalosporin that's already existed for many years, and avibactam is a new beta-lactamase inhibitor that has a structure that is somewhat analogous to beta-lactams, and it's designed to inhibit basically all of our serine carbapentamases and beta-lactamases in general. So if we look at some MICs, where this left column is for ceftazidime alone and the right one is ceftaz-avi, you can see that for KPCs, for GES, for some of our other carbapentamases, we have a huge drop in the MICs. These are very effective beta-lactamase inhibitors, and they're probably the most efficient and effective ones that have been invented and used clinically so far. One thing that's important to know is that ceftaz-avi and most of the similar drugs are not effective on most class B. And again, this is just because these class B metallobeta-lactamases do have a different molecular structure, and this molecule is not able to effectively inhibit. So here I just have a screenshot from some Spanish clinical guidelines, which are very similar to the American ones, but the table is better to screenshot to put into a presentation. So this is really emphasizing that for our Class A and Class D, these new beta-lactamase inhibitor combinations are now our first-line therapies, and other beta-lactams are our second-line therapies. So this is a huge improvement compared to 10 years ago. Things like ceftaz-avi, mirovabor, imirella, we are using not infrequently in the hospital. Class B metallobeta-lactamases like NDM have always been like the scariest ones, but again, we have some advancements in this front too. Whereas trienam avibactam is not generally available, and I really don't have time to talk about why this combination works for class B metallobeta-lactamases, but it seems to work. This particular combination is not, again, available for purchase, but a lot of guidelines, including this one and the American one, do say that we can kind of like get around it by prescribing ceftazidime avibactam and then also prescribing as trienam and like pretending that this is as if it was like, the manufactured product. There's also these cool new beta-lactamase inhibitors that have other sorts of molecular mechanisms of inhibition, like cefepime taniborbactam, which I'll talk about in a few slides, and lots of other ones that are under development. So that's very exciting. And then cefiderocol, I think a lot of us have heard about. This is that siderophotoprotein horse mechanism of inhibition, where there's not as much clinical data, but the data we have suggests that it probably is effective for all these CPEs. A few notes for prescribing is that, unfortunately, none of these are actually generally available in Canada. You do have to coordinate with your pharmacist to access these through the Special Access Program. Part of this is because of the status of approval in Canada for all these drugs, and another part is that they are extremely expensive. Like if you want cefiderocol, it's going to cost almost $9,000 just for like a 1-week treatment for whatever infection you have, plus the cost of shipping it, because again, we cannot keep this in our hospital on a regular basis. So again, this is emphasizing that we are really making a lot of progress, but it's really on like a case-by-case individual patient level. In Canada, we're not at a point where we are on a population level or even a hospital-wide level using these things in daily practice. So with that positive note, now I'll move into talking about KPC variants. So for context, the FDA approved ceftazidime avibactam at the end of 2014 and into 2015. So here, this is a little publication that has a date, February 25th, 2015. And then here, first report of ceftazidime avibactam resistance in a KPC3 expressing Klebsiella pneumoniae isolate received 17th of May, 2015. So, I think we all know that, the antibiotic arms race has been going on for many decades, but the pace of it seems to be increasing. I think that a couple of months between February and May is a little distressing. The reason that this is especially distressing is that KPC variants can mutate in multiple ways. So this is not a case of a single clone that is being spread around that is resistant to KPCs, the way that we might see with ESBLs, for example. So the KPC molecule has its active site, but it's actually not the active site that's being modified in basically all of these ceftazidime avibactam variants. It is three other sequences where there's actually a variety of different mutations, and all of these can give ceftazidime avibactam resistance. Again, none of them are at the active site, and some papers think that this is because KPC is actually like a very stable enzyme biochemically. So as a molecule, it's probably more permissive to have this variety of different mutations compared to other carbapentamases. So you can, hypothesize that if you have a patient who's got a KPC and being treated with ceftazidime avibactam, it's probably a relatively low barrier to mutation to develop one of these KPC variants under the selective pressure of being prescribed ceftazidime avibactam. One thing that's really interesting is that these ceftaz-avi resistant variants often actually lose their broad carbapenemase activity. So if on the left we look at a normal wild type KPC3, you can see that if we're testing all sorts of different antibiotics, they're basically all resistant. If we look at one of these KPC variants, KPC74, so this has acquired ceftazidime avibactam resistance, but at the cost of actually becoming susceptible again to the carbapenems. On top of that, it's also, again, become susceptible to amoxiclav and piptazo, which is quite unexpected. So again, it's not a linear progression of development of resistance. We're really seeing a lot of unusual mutations that I don't think we've really dealt with in clinical practice before. In addition to that, because there's so many possible mutational variants, there's many possible phenotypes. So if we look, in addition to that ESBL-like phenotype, we can have something that maintains KPC carbapenemase activity, where the zones of inhibition are still fairly large, but you can see imipenem definitely is not still susceptible, and it's resistant to amoxicillin and piptazo. So this is more similar to a more traditional carbapenemase. And then you can also have variants that are highly specialized in ceftazidime, where the mutation allows them to be super resistant to ceftazidime by itself and ceftazidime avibactam combination, but then it actually loses substrate specificity for basically all of the beta-lactams, including amoxicillin, which is like one of the narrowest antibiotics that exists, period, right? So this is a really fascinating area that definitely has some major implications. And one specific implication for me as a microbiologist is laboratory testing. So we can't treat these things or follow them epidemiologically if we can't find them. So how are we going to find these KPC variants? When we're normally looking for CPEs, we're really dependent on them having carbapenemase activity phenotypically. Like we're having clinical isolates that look super resistant, or we're using selective agars that contain carbapenems where they're able to break through and grow, right? So if we look at KPC variants, like some of them stay non-susceptible, but some of them are like truly susceptible by, typical phenotypic resistance testing methods to things like meropenem and imipenem. So this is where, like, if a patient with this particular KPC14 variant presented to hospital, I don't know if it would even trigger for us to even look to see if it has a KPC. Similarly, a lot of labs you do CPE confirmation using phenotypic testing, which means like you're looking for carbapenem hydrolysis. So I don't have time to go into this carbapenemase inactivation method in detail, but essentially, if we're looking at a wild type KPC2 or KPC3, we would expect to see hydrolysis of the carbapenem inside. So then like the meropenem just basically does nothing. However, for some of these variants, like this KPC35, this method does not work. The meropenem gets exposed to the enzyme and it maintains its carbapenem activity. So this is, again, a very scary thing, that something could have a KPC, but we're not able to detect that it's a carbapenemase because it's kind of not a carbapenemase by phenotypic testing. Similarly, in our laboratory, we use a lot of antigen testing as a quick and accurate method to find common carbapenemase enzymes like KPC and OXA, VIMIM, and DM. And this is dependent, obviously, on having the protein have a sequence and folding that allows the antibodies to find the specific antigen and then give us a positive result. And for quite a few of these variants, this is the same paper as before, in addition to the MICs being very different, the results for some of these are actually falsely negative, where again, the enzyme has a KPC, but the mutation affects the antigenic binding site for this assay, and it gives a control line and a false negative for the actual carbapenemase result. Finally, there's a million different ways of doing CPE confirmation, but another important one is doing genetic testing. And I think we all know that PCRs depend on the effective binding of primers and probes, right? So if you have a small deletion in any of these variable sites that I talked about earlier, is that going to impact our ability to even do like PCRs on these things? So the good news is that, this is a paper that looked at a ton of different KPC variants in China, I think, and they found that for this particular PCR-based assay, they all stayed positive. So far, it seems like the mutations that lead to ceftaz-avi resistance do not affect the primer and probe binding sites of typical commercial assays for KPC. But again, in the future, who knows what is coming. So that's very scary. And then management is also very scary because, like, what do we do, right? One thought is that we could use ceftaz-avi in combination with the carbapenem, with the idea being that, this is a particular patient where they had an isolate that was a KPC variant that was susceptible to carbapenems and resistant to ceftaz-avi, so kind of that ESBL phenotype. So at that point, they were on ticacycline and imipenem. And then later, they had another isolate, which was, potentially a reversion of isolates that were in the gut or something, that was KPC2. And this one had reverted to the wild type, resistant to carbapenems and susceptible to ceftaz and avibactam. So these doctors said, well, I'm just going to do both, I guess, and do imipenem with ceftaz-avi, and this patient survived. However, here is a paper from New York where basically the same thing happened, where there were 3 different phenotypes and the patient kind of bounced between them and got ceftaz-miro and then ceftaz-avi and then miro, and this patient died. So we really do not have good evidence that this is going to work in general. Similarly, if we look at other novel beta-lactamase inhibitors, I don't have time to go through the data, but things like mirapen and vaborbactam sometimes look susceptible in vitro, sometimes look resistant in vitro, so this is not a reliable treatment for these variants. And similarly, even cefiderocol. Here's a paper entitled Co-Resistance to ceftaz-avi and cefiderocol in clinical isolates with KPC variants. So again, this is a very scary thing. We really need to proceed with caution and consider that we can't just assume that any of these novel agents are going to work. Moving on to another scary topic. So metallo-beta-lactamase variants are also something we have to be concerned about now. So I'll start on the positive side that cefepime-taniborbactam is a very exciting drug being discovered, where taniborbactam is the first inhibitor that's really active against class B metallo-beta-lactamases. This is because the biochemistry of it is somewhat different in that it's based on boronic acid, which is able to inhibit the metallic enzyme activity of these carbapenemases. So if we look at kind of the regulatory environment, cefepime-taniborbactam is not yet approved anywhere, but we have this paper hot off the presses, February 15, 2024, in the New England Journal of Medicine, giving us some good clinical evidence that cefepime-taniborbactam works in sick patients. So hopefully this will lead to approval, within the next year. However, here we have an article, NDM9 resistance to taniborbactam. And the bad news is that this is not February 13th, 2 days prior. This is 2023, a whole year prior. So again, in the antibiotics arms race, like we are spending millions of dollars and trying our best. And sometimes the bacteria are even like psychically ahead of us in terms of having resistant mechanisms already ready to go. So this is one particular paper that was comparing NDM1 and NDM9, where there's a single amino acid substitution difference, and it leads to a significant increase in MICs to the cefepime-taniborbactam combination. So again, like this is not very exciting. There are a bunch of other things that are coming down the pipeline, like cefepime-zidibactam. So for this particular variant, it looks like these sorts of things still are working in vitro. But again, like this is just one variant, and there's dozens and dozens of these variants that are out there and could develop further in the future. And it's not just NDM. So here's some of those NDM variants where you can see that NDM9 and NDM30 have these increased MICs, but you can also see that there are some VIM variants that can also be resistant to taniborbactam. And it looks like IMP as a family in general is intrinsically resistant to taniborbactam. So this really emphasizes that, again, even though we're developing these new and very exciting drugs that do, again, probably work on a population level right now, any of these class B enzymes have a potential for resistance in the future. So that's all that I wanted to talk about today. So my takeaways from preparing this presentation really are carbapentamases are more complex than previously thought. The rates of resistance are constantly increasing, and who knows where we're going to be 10, 20 years from now. Sadly, ceftazine, avibactam, ceftriaxone, other novel beta-lactams are not our saviors. They're not going to be the end of the line for drug development for this. And I didn't get into it, but there's a lot of other non-beta-lactams being developed. But again, there's lots of resistance to those two that's developing. Because of that, clinical microbiology labs must be prepared to expand testing in the future. This data really shows resistance to novel agents is unpredictable. We can't just prescribe ceftaz-avi and assume it's going to work. Similarly, routine CPE testing methods may not be sufficient in the future for variants. So again, right now, as far as we know, KPC variants are not common in Canada. But again, if one showed up in our laboratory today, I don't know if we would catch it. So that's something we're going to have to think about as these become more common on a global scale. And then finally, this is just further evidence that the arms race against AMR is perpetual and unfortunately appears to be escalating. So this really emphasizes that the discovery of new antibiotics is crucial, and I will leave it to Dr. Stokes to talk a bit more about that. And I think that better detection of specific AMR genes to allow us to have more targeted antibiotic use, especially now that we have this data that shows that we can't assume that classes like KPC and NDM all have uniform phenotype. And I'll give myself a little prompt that this is part of the bioinformatics work that I am doing in the work of Dr. Andrew McArthur to kind of address that from a sequencing perspective, which I think a lot of experts think is probably the future in terms of detecting these sorts of enzymes. So that's everything that I wanted to talk about, and I will pass it on to Dr. Stokes.
Thank you for having me and for everyone for waking up so early to listen to talks about AMR stuff. I mean, following Brody's remarkable talk is going to be hard. I think you're all in for a disappointment. But and I'm going to talk about, discovering novel antibiotics against gram negatives, carbapenem resistant or not. Let's focus on carbapenem resistant, let's say, for the sake of continuity. And I'm going to talk about, discovering novel antibiotics leveraging computational approaches based largely in machine learning and deep learning. I'm going to talk about abomanii today, but I want everybody to keep in mind, so whenever I say abomanii, it doesn't just mean abomanii. These types of approaches can be applied, across, discovering new antibiotics against phylogenetically diverse pathogens and indeed across disease areas as well. Okay, so we've all seen this, but bear with me, I'll be quick. We've had antibiotics now for the better part of 100 years. The overwhelming majority of our current clinically used antibiotics were discovered between the 40s and the 60s. And this was the golden era of antibiotic discovery, and we found a bunch of different structural and functional classes of antibiotics through natural product mining. So these are molecules that were made by soil-dwelling microbes. Come, the middle of the 60s, 70s, we ran into this issue where we kept discovering the same antibiotics over and over again. And as such, in more recent decades, we've turned to alternative technologies such as high-throughput screening of synthetic chemical libraries in an attempt to discover new antibiotics that can be used in the clinic. Unfortunately, as we can see here on the right of the slide, more modern, dare I say, technologically sophisticated technologies such as high-throughput screening have failed to yield any clinically used antibiotics. And of course, we find ourselves in this discovery void. So what accompanies, as we all know, our alarmingly lean antibiotic pipeline is the global dissemination of antibiotic resistance. For perspective, in 2019, 1.3 million people died to a drug-resistant infection, and without immediate progress in discovering, developing, and clinically implementing new antibiotics, that number is expected to grow to 10 million per year by the year 2050, at which point AMR will surpass cancer as a cause of death. Okay. So why do I think that AI approaches can help us address this problem? So if we want to distill, let's say antibiotic discovery into the simplest possible concept, if we know that antibiotic resistance is going to evolve to any drug that we discover ever, we consistently need structurally and functionally novel molecules. And given the economic challenges that are currently associated with antibiotic development, that means we need to do it quite inexpensively. So what we need is a technology that allows us, to more rapidly and less expensively identify promising chemical matter that could be applied as antibiotics. And I think that AI is one approach that could address this challenge. All right, so if we look on this slide, we'll go through this really quickly. On the right-hand side of the slide, we see like a conventional small molecule screening approach. So here, we can test maybe hundreds of thousands to a couple million molecules at the largest of scales against our bug of interest, carbapenem resistant something, let's say. We get our hits, and then we chase the hits in which we're most interested, and we think has the most promise and, some translational capacity. This approach is limited across a few dimensions. So first, it's quite expensive because if you want to test a million molecules, you have to buy a million molecules. Two, it's slow because if you want to test a million molecules, you have to run a million experiments. And three, we often find that these currently available chemical libraries don't often explore chemical spaces that are ideally suited for antimicrobial applications. They're often developed for, cancer or fibrosis or, other like what I'll call like human-centric drugs. We can now contrast this approach with an AI-guided drug discovery method here shown on the left. So in an AI guided discovery method, what we end up doing is we first gather a training data set, we train a model, and then once we're happy with the model, we can then run predictions. So in the context of gathering a training data set, we often find that we don't need to screen, hundreds of thousands to millions of molecules to train a good model. We can often train, thousands to, low tens of thousands, and we can get a very robust model. So in that context, we're saving, a lot of money because we don't need access to a million. We only need access to 10,000 compounds. Then we can train a machine learning model, and once our model, we're happy with the performance of our model in silico, we can take that model and run predictions on in silico chemical repositories. And of course, as we could all intuit, we can run predictions in a computer orders of magnitude faster than we could run experiments in a laboratory. And because we can run predictions orders of magnitude faster than we can run experiments in the laboratory, that affords us an opportunity to explore a really broad chemical space in silico. So it's for these reasons that we think that, AI approaches can, help us address this problem of, discovering new antibiotics quickly and, for less money than it currently costs. All right, today we're going to talk about Acinetobacter. I think it's my favorite bacterium. I'm pretty sure. It's a hospital-acquired pathogen, often, multi-drug, extensively drug, or pan-drug resistant. It's really virulent, causes a lot of different types of infections, bloodstream infections, pneumonia, meningitis, wound infections. And, mortality is particularly high with this bug, something like 1 in 4, maybe even a little bit higher. So, given that it's such a challenging bug, we figured, this would be a good pathogen to try to discover new antibiotics. Okay, so we're gonna have, two sort of distinct discussions this morning over the next, 20 minutes or so. The first, we're going to be talking about discriminative modeling. So this is a type of AI algorithm that satisfies this use case. So I have pictures of cats and dogs, but all the cat pictures in one pile and all the dog pictures in another, right? So based on this sort of use case, you can see that this model is designed to look at pictures of cats and dogs. So we just show it pictures of cats and dogs, and it puts all the cat piles in one pile and all the dog piles in another, right? But we can immediately, replace cats and dogs with like antibiotics and not antibiotics, and we get the same thing, right? So replacing cats with antibiotics and dogs with not antibiotics, it says, I have pictures of antibiotics and not antibiotics. Put all the antibiotic pictures in one pile and all the not antibiotic pictures in another, right? So pretty straightforward. And then on the second half, we're going to talk about generative modeling. And this is a slightly different type of model that satisfies this use case here. So draw me a brand new picture of a cat that does not look like any of the cats you were trained on, right? So of course you have some model, you train it on tons of pictures now of antibiotics, right? And then we just say, draw a picture of an antibiotic that doesn't look like any of the other antibiotics you were trained on, right? So discriminative modeling, you show up pictures of stuff. Generative modeling, it makes new examples. So let's start off with a discriminative modeling project real quick. So this is a paper that came out in May of last year. So in this one, all we wanted to do was to train a discriminative model to predict novel antibiotics against Acinetobacter. So what we had to do, of course, is gather a training data set that we could use to train a model to understand what structures of molecules that could inhibit the growth of Acinetobacter looked like. So we went into the lab, screened 7,500 or so molecules. This on the vertical axis, we have growth of Acinetobacter, and then molecule index, just all the 7,500 compounds that we tested. Everything in blue, we said, did not statistically inhibit the growth of Acinetobacter. Everything in red, we said statistically inhibited the growth of Acinetobacter. So importantly, every dot in this plot is a different molecule, and we know the structure of every compound in this library, right? So what we have now are, 7,500 structure property pairs, right? So if it didn't inhibit growth, we labeled it with a 0. If it did, we labeled it with a 1, right? So we have 7,500 structure property pairs. And this is a really good data set that we can now use to train a model that can take as input chemical structures and then output a property, whether the model thinks something new is antibacterial or not. Okay, so I'm not going to get into the weeds here. We can talk about it, over coffee sometime. But how all of these models work is these models learn to understand chemical features in the context of some biological property. So for us, based on the training data set that I just discussed, the model is learning to understand the features of chemicals in the context of whether some chemical can or cannot inhibit the growth of Acinetobacter in vitro, right? So you start off with some, structural representation of a molecule. This is called a molecular graph, in nerdy language. So a graph in computer science is nodes, which are atoms connected by edges, which are bonds, right? So this is called the graph structure of a molecule. And there are many, many ways to do this, and we employ many different ways in the lab. But what we want to do in order to train an AI algorithm is to convert this graph structure of a molecule into a vector. And all a vector is a really long string of numbers that describes something, right? So what we're going to do, and again, I'm not going to go into, is we'll take some molecule. Let's say this is your molecule. We're going to convert it into a long string of numbers, right? Which every node here is a different number that represents, some feature of this molecule. And then this long string of numbers, this vector, then serves as an input vector, an input layer to a feed-forward neural network. And all a feed-forward neural network is something that transforms, a long string of numbers into different strings of numbers until you get to some output. And for us, the output layer is a prediction score, of course, between 1 and 0, representing whether the input molecule, right, which is represented as this input layer vector, right, is antibacterial or not, right? And it's called a feed-forward neural network because, as indicated by this arrow, all the information is flowing in one direction. So we have our input vector, some, vector transformation of this vector, another transformation of this vector, and then we have our output. Right? We don't have to get too weedy here. All we have to know is we're taking a molecule, vectorizing it, and that vector then becomes an output 1 or 0. And when we say we're training our model, what we're training the model to do is learn how to convert this input layer, this input vector, into a number that maximizes the classification accuracy. Okay, so we're here. We have 7,500 structure property pairs. We train our machine learning model. And now this discriminative model, right? Once it's trained, it affords us the opportunity now to show this model brand new pictures of chemicals it has never seen before. And based on what it learned during training, that model will convert this graph structure of the molecule, right? That's the molecular graph, into a vector. And then that vector will go through a series of transformations until we get to an output. And if, in this case, the output is 0.15, this model, based on what it learned during training, doesn't think that this input molecule is likely to be an antibiotic. Okay. So after we trained our model, remember we had 7,500 compounds. We trained our model. We ran predictions on a really small chemical repository, the drug repurposing hub at the Broad. And then we got the prediction score, right? That number between 0 and 1 for every molecule in the drug repurposing hub. And that's what we're plotting here, from lowest to highest, molecules that have low prediction scores and molecules that have high prediction scores. And if we look at the shape of this plot, what does it say? A handful of molecules have high prediction scores, and most of them have low prediction scores. And that fits with what we know about, existing medicines, right? That exist in the drug repurposing hub. Some molecules are antibacterial, but most of them are not, right? So this distribution fits like our intuitive understanding. So, okay, this is cool, right? And practically, this is cool because, we don't necessarily have to screen 8,000 compounds. We could super easily, but, we don't necessarily have to. Now we only have to look at, I don't know, a few hundred molecules that the model thinks to be antibacterial and not all, 8,000. So that's what we did. We took all these molecules, tested some of them in the lab, and then we came to this molecule here. The part that I glossed over there is that we're not, like, all of these molecules aren't, I'll say, like, not created equal. When we're looking for new antibiotics, especially those that, can overcome pre-existing resistance, we're looking for novel molecules that are structurally and functionally novel relative to everything else we have. So I should say that we pre-filtered all these molecules for structural novelty. All right, so we got this molecule here. We named it Abicin. It had an MIC of 2 micrograms per mil against Acinetobacter in vitro. It was modestly bactericidal, a log 2 maybe. And at first, we were kind of interested, but not super interested. And what got us really interested in this molecule is when we ran this experiment here. So every dot is a different clinical isolate, right? So growth on the vertical axis. So we tested this molecule against a clinical isolate panel of Acinetobacter, carbapenem-resistant Enterobacteriaceae, Pseudomonas, and staph. And you can see that as we increase the concentration of Abicin, we can inhibit the growth of every clinical isolate of Phaebomoniae, but it does nothing against CRE, pseudo, or staph, right? So this data, and of course, other data that we gathered using commensals, was strongly suggestive that this molecule was Acinetobacter specific. So that's why we got really excited, because we had something that was, preferentially active against Acinetobacter and nothing else. And this was cool, but then we asked the question, this is a very unique phenotype. We don't come across narrow spectrum antibiotics particularly often. Why is this narrow spectrum? What is the mechanism of action? So we evolved some resistant mutants in the laboratory, and they all map to this gene, the gene that encoded the protein LOL-E. LOL-E is involved in lipoprotein transport. We then did some genetic experiments. We did a bunch of experiments, but for the sake of time, I'll focus just on a couple. We did a LOL-E knockdown experiment. So using CRISPR-I, we knocked down LOL-E, observed that Abicin had an increase in potency when we knocked down LOL-E as expected. And of course, in one of our mutants, we had a mutation upstream of LOL-E, and it turns out that that upstream intergenic mutation increased the basal level of expression of LOL-E, and of course resulted in resistance. We tested the compound in a wound model of infection of Acinetobacter, and it worked okay. All right, that's fine. So let's go back to AI for a bit. What I just described, this discriminative modeling approach, works well, but it doesn't scale very well. So for example, we can run, tens of millions of predictions a day, something like that. But in order, to make this discriminative approach, I'll say like time effective, you don't want to be running predictions any more than like a week or two, right? Because then you're just sort of sitting around waiting. So for all practical purposes, discriminative modeling can't explore anything more than like 1 billion compounds, which actually is not that much, especially when considering that drug-like chemical space is on the order of 10 to the 60. But like 10 to the 60, this number doesn't really mean anything. It might as well be like infinity billion infinity squared, because our solar system, for reference, has 10 to the 57 atoms, right? So like we'll never be able to explore 10 to the 60 molecules, but how are we more able to search more of this potential, theoretical 10 to the 60 drug-like molecules that could exist, right? So we can't do it with discriminative modeling because it scale, like the time it takes, the computational time it takes to run discriminative models and run predictions scales linearly as the size of the library increases. So this is where generative modeling comes in. So I'll say a lot of people have done generative modeling for molecules. Like, this is not a new idea. This is an old idea. The issue is that most of the molecular generation algorithms that have previously existed, they build molecules atom by atom. And that sounds like a really good idea, right? I can explore theoretically any chemical space, build any chemically valid molecule. The issue is when you want to take that molecule and synthesize it to test it in the lab. Oftentimes, not always, but often we find that a lot of the molecules that have been designed by previous generative algorithms are synthetically, quote, intractable. They're beautiful to look at on a computer screen. We can't synthesize them and test them in the lab. So for us, that's like a non-starter. If we can't pick up a pipette and test the molecule, we're not like looking at it. So when we set off to work on this project, we said, can we develop a generative algorithm that outputs molecules that are synthesizable and ideally pretty cheaply synthesizable? So working with a really good buddy of mine, James Zoe, who's a computer science professor at Stanford, we developed this algorithm called SynthMol. I'm going to walk you through it super quick at a high level, and then we'll sink our teeth in for a few minutes. So we're going to start here. We first gather a training data set because that's just sort of the default for all of AI. So we have our training data set. We've already seen this. Then we have our property predictor. We've also already seen this, right? Okay. The way that we got our model to only build molecules that were synthetically tractable is we didn't let it build molecules atom by atom. Rather, we gave it a predefined set of molecular building blocks. So we gave it 132,000 molecular building blocks for which we knew the structures of every one. And we also gave the model 13 well-defined chemical reactions. What's important is we know, using these 13 reactions, the reactivity of every building block with every other building block, right? Molecular building block. So that gave us access to a 30 billion compound chemical space, which would be impossible to test using a discriminative modeling approach. Okay, so given that our model had its molecular vocabulary with which it could work, 130,000, what we trained this model to do was to learn how to take two building blocks and stick them together in a way that made a molecule that looked antibacterial, at least according to our property predictor. Okay. And then, we did this 20,000 times. We got this SynthMol algorithm to build 20,000 compounds by taking two molecular building blocks and sticking them together. And then we took some of the molecules that looked really, really good, at least in silico, synthesized them, and then we tested them in the laboratory. So the only thing that's different here is like the molecular property predictor is still like looking at pictures of molecules. It's just that the pictures of molecules it's looking at were generated by another part of the algorithm. We just didn't show it chemicals that were sitting on a shelf on some website. But everything else is conceptually the same. Okay, let's motor through this. So we gathered some training data. So this time we had 13,500 molecules that were all structurally very diverse. That was key. And then we actually used 3 different molecular property predictors. So remember I said we have to take the structures of molecules, convert it into a long string of numbers. That's a vector that we then use to make predictions to train a model. We did that using 3 different quote architectures. And that was to ensure that we had different models converging on the same answer. That just makes our predictive models slightly more robust. So these 132,000 molecular fragments came from this thing called the real space by a chemical company called Enamine. So these 132,000 molecular fragments, again, structurally diverse. We know the reactivity of every fragment with every other fragment, and we can now search this big space to make antibiotics. And this is how our molecular design process works at a very high level. So We take all 132,000 building blocks, we show them all to our pre-trained molecular property predictor. That's the model that was trained on the training data set. What happens then is we run predictions across all 132,000 building blocks, and we pick the building block that has the highest property prediction score, right? So the property predictor says, I think this molecular building block is the best, so use it. We then say, okay, we're going to pick this molecular building block. We then say, what other building blocks is this first building block synthetically compatible with? So it's not 132,000, it might be like 50,000 or 60,000, right? So we say, here's our first building block. It's synthetically compatible with these 50,000 building blocks. Which of those 50,000 building blocks is also most likely to be antibacterial, right? So we pick it. And in this case, it happens to be this one. We then take these two individual building blocks, and through this reaction, they happen to be synthetically compatible through reaction 11. We build this final molecule that we then show to the molecular property predictor. In this case, the property predictor says, hey, that you built a really good molecule. And what happens is this prediction score now, right? The property predictor gave it this full molecular prediction score of 0.9. This very high score is now, quote, back propagated to update the scores of the individual building blocks that went in to build that molecule, right? So what this means is you can, and I should say actually, if this property predictor gave this molecule a very low score, that low score would also be back propagated, and it would decrease the scores of the building blocks to make that made that final molecule. So over time, tens of thousands of times, what the model is learning, right? This part of the model, the synthmol molecular design part of the model, is learning which molecules tend to build good antibiotics and which molecules, which molecular fragments, building blocks tend to make bad antibiotics, right? So what we're trying to do is after this synthmol algorithm has learned which building blocks make good antibiotics and which molecules don't make good antibiotics, and their associated building blocks, of course, is over time, it's going to learn how to traverse chemical space in a manner such that it can more reliably build good antibiotics, right? It's going to know which building blocks to select and in what manner in order to build, high-scoring molecules that could look like antibiotics. So what we did is we did this, 20,000 times. We prioritized 58 molecules for synthesis, and 6 of them worked, and here are their structures. Okay, cool. We have, I don't want to talk about that anymore. I'll give you a sneak peek. And this is, I haven't mentioned this publicly yet. So we have a bunch of ongoing efforts in the lab. We have like deep reinforcement learning models for molecular design. So this is synthmol, except it just selects building blocks slightly differently. We have chemical language models for molecular design. So think of like ChatGPT, except it builds chemicals. We're leveraging in vivo omics to define ideal antibiotic targets in the context of infection. And this is something that I wanted to bring up for this audience specifically. So we're developing now a set of web-based molecular property prediction tools. We're calling it the ESCAPE model. So we're building this website in collaboration with the MacArthur Lab, where anybody can upload their own molecules, and this model will run predictions across all of the ESCAPE pathogens to see whether new input molecules that are uploaded by you or whoever on the other side of the world are antibacterial. This model isn't quite ready for prime time yet, but I think, by late spring, early summer, this will be up and running, and then everybody can upload their own molecules and then have predictions ran for you. So that's it. So thank you for paying attention.
Thank you so much. Very thought-provoking, terrifying, exciting talks. So for questions, we have a question for Brody. Antibiotic use for CPE for adults, can they be used for peds, or are there specific recommendations, if I was to paraphrase?
Yeah, so it's a very good question, and definitely one that like clinicians around the world deal with every day. Like essentially, for antibiotics, like children are not little adults when it comes to medicine, but in terms of like the actual bacteria that they're infected with, like if an adult has E. coli and a 4-year-old has E. coli, you can kind of generally treat them the same way. One thing that I didn't have time to get into today is like the pharmacokinetics and pharmacodynamics of these antibiotics is very difficult to kind of predict, and we need more clinical data on that. So that's where if you have a very unique patient population, like a 2-year-old baby with meningitis and sepsis, it's hard to say if ceftazine avibactam would actually work clinically. But again, when these patients have CTEs, sometimes you're really grasping at straws. So I think that's an area where definitely like case by case basis.
Okay, thanks. Question for Dr. Stokes. Do you ever filter out molecules if they are known to have toxicity?
Oh yeah, so I brushed over that too. We have a bunch of models that are trained on existing, toxicity data. So all the molecules that are outputted that are predicted to be antibacterial and are structurally novel, we run them through these in silico toxicity prediction filters. The available training data, I'll admit, for toxicity prediction isn't fantastic. So we're in the lab, we're currently looking for ways that we can gather our own toxicity prediction data across a whole bunch of different human cell types. Because, what we're ultimately working towards, in a perfect world is something that resembles like a fully automated preclinical, I'll call it like suggestion pipeline. So you start with a giant pool of molecules, billions, trillions of molecules, and then you filter these compounds through whatever filters you deem necessary for your therapeutic application. And then at the bottom, you're left with a manageable pool of compounds. And then it says, these are likely to be good antibiotics that, aren't toxic everywhere. And, they're not going to be immediately metabolized and. But I mean, we're probably like, we're still a bit away, but that's what we're working towards.
Yeah, I feel like it's easier to gather the training data for the antimicrobial aspect of it than for the toxicity, the metabolism, because that detailed work has only been done for such a small set of compounds.
I know.
Yeah. A question from Dr. Smale. Can you use AI to predict how quickly resistance will develop?
So that's such a crazy question. So like 2 days ago, I was talking to a friend of mine who has just published a paper who did prediction of viral evolution in the context of it was influenza. Hang on, I skimmed the paper. I didn't read it very well. It was influenza evolution in the context of like what influenza vaccine was given the year prior or something like that. So we were talking, it's like, can we do this same sort of approach for antibiotics and subsequent resistance in an attempt to design novel antibacterial molecules for which pre-existing resistance would be less likely to have activity, but still might exist. Like you still might be looking at beta lactams, let's say, but can we develop a beta lactam that has structural features that make it less susceptible? So theoretically, yes. I mean, virus people are doing this right now. The issue that I think we might have, and again, I haven't looked into, is like, do we have sufficient quantities of available data, like surveillance data, let's say, such that we can train a robust, like, protein evolution model to be able to model this type of stuff?
I feel like
the technology exists.
You and Brody need to connect on the KPCs, because I feel like that use case is probably very cool, because if you have these weird insertions and deletions and SNPs that give you unpredictable, maybe it's not unpredictable if you train an AI to tell you, what's the likely consequence if you use this drug and this enzyme.
Yeah.
Very cool. Okay, we're out of time, so I'm just going to say thank you again. Those were awesome talks, very thought-provoking, and as I said, a little bit terrifying when I saw that 50% KPC rate. Hopefully it stays where it is for now. So thank you both, and thanks everybody for joining us. I'll see you next month.